Good evening, everyone, and welcome to the first intercollegiate webinar on behalf of the Deans of the Faculties of the Dental Surgeries of Glasgow, which is Mr. Andrew Edwards is a panellist this evening, the Faculty of General Dental Practice, Mr. Ian Mills, the Faculty of the Dental Surgery at the Royal College of Surgeons of Ireland, Mr. Albert Lung, or Professor Albert Lung, and we're shortly to be joined hopefully by Professor Fraser MacDonald by the Royal College of Surgeons of Edinburgh, and myself, Michael Escudier from the Royal College of Surgeons of England. We thought it would be helpful for us to come together today and hopefully in the future as needs dictate at a time when we've seen unprecedented changes both to the way that we within the faculties are operating, our host organisations are operating, and indeed pretty much every organisation around this country and throughout the world has had to organise, including those of our members working in their practices and in their hospitals. So welcome, thank you for joining us. And we're going to start answering questions which we've had sent in advance, so thank you very much to people who've done that, and also questions as they come into this evening. So first question is going to be read out, I think, by one of our narrators.
Narrator. Okay. Hi. So the first question is regarding the big elephant in the room. So some dentists who are providing urgent care have concerns regarding the level of PPE that they are being advised to wear, as there is lack of clarity as to which aspects of dental care constitute an AGP. Could this be clarified?
Okay, I think it is, as you say, the big elephant in the room, and I was going to pass that over to Andrew Edwards in the first instance, if I may. Andrew.
Thanks for that, Mike. Just like to welcome everybody. And I think, first of all, just to say a big thank you to everybody out there, whether you're a dental student, an FY, whether you're a CT, a DCT, an ST, you're in practice, you're in hospital practice. I hate using the word unprecedented, but it's been used several times. We are in unique times, but it's just to say a big thank you to all the members and fellows of all the colleges, really, for all the work that's been going on out with the scene in dentistry, basically. So it's a huge thank you from us all, basically. We know how much of a strain it's put on you both in general dental practice and hospital practice. A lot of you are working out with your comfort zone. So first of all, just to say a big thank you. PPE, yeah, the big elephant in the room, where are we basically? Well, there's been a lot of guidance that's come out, some good guidance, some not so good guidance, some delayed guidance, basically. We've looked at it. The beauty of being colleges is we are apolitical. However, we can influence our political masters, basically, which is something we are actually quite good at. Regarding going forward, we've taken a whole lot of evidence, and the evidence out there comes from a number of areas. There's a lot of evidence from China, because obviously that's where the virus started, and there's been a lot of evidence there about what constitutes adequate, what constitutes inadequate PPE. A lot of it revolves around another elephant in the room, AGPs. We are hoping tomorrow to have a consensus around the use of PPE, particularly with regards to dentistry. The problem that the guidelines have is they are very scant when it comes to dentistry and the practice of dentistry and what constitutes PPE, what constitutes an AGP. So hopefully we're getting some clarity out there, and we're all signed up to it. All four CDOs are signed up to it, and the whole idea is to bring out a consensus document which will give some structure, some clarity around what constitutes adequate PPE for people, whether in dental practice or whether it's been in secondary or indeed tertiary care. And I think Mike can probably shed a little bit more light on what we're intending to do, hopefully over the next 24, 48 hours.
So I would hope, as Andy said, we have been very fortunate to be able to secure a meeting to discuss this, to try and get the clarity that people have been seeking. But obviously, it's a very fluid area, and the guidance that's produced at any particular time may need to be changed in light of new evidence that may be presented as we go forward. But as Andrew said, we are hoping that we will be able, in collaboration with the relevant organisations and their expertise, particularly around the evidence base, to bring forward a proposal that should give good clarity to the whole of the dental workforce. One of the key things to say, however, is that people should be actively seeking to do as few aerosol generating procedures as possible at this time. So that's the first thing. Really ask the question, do you need to use an aerosol generating procedure? I think there'll be good clarity around that. But also, as you heard on the Chief Dental Officer's webinar, some of you perhaps last Friday, there is a document in process within England, and there have been other guidance documents produced within Scotland and Wales and Northern Ireland around some general principles, remote prescribing and remote consultations, and also about how you conduct face-to-face and indeed clinical treatment in the present climate. I don't know if either of the two other deans present would like to add anything, Ian or Albert.
Yeah, thanks, Mike. I think the lack of clarity around PPE is a real issue and has been for the last few weeks. And I think that has stoked the anxiety that certainly within general dental practice there has been. And I think absolutely we'll welcome greater clarity around that. There is a lack of evidence, I would suggest, at the present time, and we're learning all the time. We're learning from other countries who are ahead of that. But when we start to build that guidance, we need to be clear that actually how we implement that will very much depend on the risk-based approach that we take, and that will be for different practices, different individuals. It'll also be different points of time. That risk may vary. So I think we have to be flexible with that guidance. Because the priority has got to be at the moment around safety, and that's safety for ourselves, safety for our staff, safety for our patients, and also safety for the wider community. And that has got to be our primary concern moving forward.
Okay.
And if I may just come in, as far as the Royal College of Surgeons in Ireland is concerned, the Irish perspective is concerned, dentists in Ireland receive guidance from the Health Protection Surveillance Centre, from the CDOs, and from the Dental Council in Ireland for those who actually practice in Ireland. There is a much wider consensus as to how it should be carried out, avoidance of aerosol generating procedures, etc., etc. There's no universal agreement on a lot of the things, but obviously, for obvious reasons, for the safety of the patients, some days concerned, need to maintain it to as high possible standard as possible as far as using of masks, etc., is concerned. So the moving target is the moving goal for everybody. We are just trying to do our very best for our patients. That's the main thing.
Okay. Professor McDonald has now been able to join us.
No comment.
So, I hope that's given some people some food for thought around PPE. I do know that all of the bodies within the both England, Scotland, Wales, Northern Ireland, and ERA, it is an area that they've all been actively working on, and I think a big thanks to all of those individuals in all of those organisations, be it Public Health England or their equivalents, for all their efforts on our behalf. And as I say, we hope to be able to bring you with them some new information in due course. Jane, I wondered if you move on to the next question, perhaps.
Yeah, certainly. So we've had a couple of follow-up questions on the PPE, which we could start with, and hopefully it doesn't raise any more questions. So somebody is asking for advice on how you would gain written consent when donned in full PPE.
I'll maybe take up on that if I can, Jane. I mean, the way I work, I'm a maxillofacial surgeon, so we've been seeing a lot of patients in the secondary care centre with regarding that. So what we're doing is we're having what we call a triage room, and the triage room would be a face-to-face contact only with that patient. That would be taking a history, for example, taking a consent form, doing any of the paperwork, taking the x-rays if there was any x-rays, getting the x-rays together. So when that patient then went into the room, that the second clinician would be donned in the appropriate PPE. And I use the word appropriate PPE, whether that be a fluid-resistant mask, which would be an FFP3 with the gown and the full PPE, then that's fine. But that's the way we do it in hospital practice. Now, that might be difficult to do that, but essentially it does require two clinicians to do that, and that negates you having to take consent, then don, and then doff the PPE. So that might be one way around it, is to use two clinicians, one doing the paperwork, taking consent, doing up the pre-work in that, so that the individual who is possibly in a separate room, if possible, which has minimal apparatus in it, etc., and minimal staff in it, can actually carry out the actual procedure in the PPE of which is appropriate to that procedure, whether it be an aerosol generated procedure or whether it just be a straightforward examination of the oral cavity, avoiding any aerosol generated procedure. I hope that makes sense. I don't know if any of the other deans have got any comments on that.
I think Andy makes a good point that actually we're probably in a much better position to have informed, valid consent in terms of the triage and the screening and the level of communication that will take place with the patient before they actually cross the doorstep. You know, I am no expert on consent, but consent is just not about the written document or a signature on a consent form. It's much more about communicating to the patient the benefits and risks of treatment, and also ensuring that they have understood that. And I think we're probably in a better place at the moment to discuss that with the patients when we've got less pressure on our time. But clearly the level of consent probably extends beyond just the clinical aspects. It's also about the risk of exposure to coronavirus and the risks involved there.
I think Ian's right. It's very daunting for, and we've had a few patients that have come through to see me or one of my colleagues doffed in full PPE with gown, mask, visor, and all they can see is your eyes, really. So it's a bit disconcerting for individuals to come in and see you in the PPE. So beforehand, as Ian says, maybe and part of the consent process is actually informing them and telling them that we are in, and I don't want to use unprecedented again, but you're in a unique situation, and patients will accept that basically if you do inform them beforehand and say, look, you know, this is the environment we are in. I mean, nowadays, with social media, on the news, people are seeing it all the time, people dressed in full PPE. So it's not to be unexpected, basically, if they are going for a dental or a hospital procedure, basically.
Okay. I mean, whatever you're dressed in as such, the patient needs to have the capacity to be able to do so, to consent. It has to be voluntary, and most importantly, these days now you have to give the right amount of information for the patient in respect of the risks involved, in respect of results, etc. So I think information-wise is very important. As I say, this is a moving target, it's a moving information that we need to give to our patients, particularly in relation to COVID-19 and the related matters.
Okay. Jane, any next question? That's not a follow-up, you were saying.
We've got a few people asking about emergency treatment and how that should be being dealt with in lieu of the hubs being ready.
Mr. Mills, perhaps pass that to you as you're wrestling with exactly that challenge, I think, in the call.
I certainly consider myself speaking with experience of this at the present time. We're in a compromised position at the moment across many areas of the UK, but I think certainly I would state that we are in parts of England. And you know, I said earlier that safety has got to be our primary concern, but not far behind that is obviously looking after our patients, patients in pain, patients with infection. And it's disappointing that in many areas of the country we don't have the urgent dental centres up and running, but certainly I'm reassured on a daily basis by various individuals and organisations that this is happening as we speak. One of the issues is obviously around the availability of PPE, and it's difficult to argue the toss maybe when we've got ITUs and A&Es that don't have access to PPE, but it is something that we have to get in place, and we have to get in place rapidly so that we can provide an urgent dental care service for our patients. Because if we don't, the problems are going to mount up, and these patients who need the care are going to spill over into secondary care and put additional pressures on them. So at the moment, I'm afraid it's back to the 3 A's. And just trying to give palliative care in the majority of situations.
Jane, I think probably good if we move on to some of the other areas that people have raised, one of which was concern by trainees around assessments and around their training. So that's certainly something that the colleges have been actively engaged with Health Education England and CopDend. who have released a really helpful statement to say that all of their measures are aimed at trying to minimize any impact on training. There was a comment from one of the questions about surgeons being delayed. My understanding, and my other deans can correct me if I'm wrong, but my understanding is that COPDENT and HEE and the other devolved nations are very keen to avoid delay to anyone's progression through training, if at all possible. To that end, the colleges are actively seeking to recommence those exams that we'd ceased recently by having to cancel because of social distancing, by moving online. And I'm minded that the intercollegiate specialty fellowship examinations are run from the Glasgow College, and whether Mr. Edwards would like to make any comments.
Cheers, Mike. Thanks for that. Yeah, I mean, that's obviously got an impact. And as Mike said, what we don't want to do is this pathway is a dynamic pathway. So if we block this pathway anywhere from entry level, which is the undergraduate going in, or coming to the specialist coming out, whether that be at specialist level or indeed consultant level, there's a logjam. That's got either a downstream effect or indeed an upstream effect. So what we don't want to do is cause a logjam anywhere along that line. Unfortunately, we have, as of March the 15th, I think, and all colleges did, right across all exams, which includes medical, surgical, and dental exams, suspended at this moment in time. As Mike said, we don't want to have an impact on any individual's training. Now, that's anybody from dental core training to specialty training, and ultimately coming out of specialty training. We don't want to impact on that. We're looking at a number of novel ways to try and deliver examinations rather than the traditional way that we often do examinations, which is a lot of it is face-to-face, for example, you know that. So all the colleges are looking at different ways of actually delivering the exams using different platforms. And this is something that we're doing quite actively across all colleges. With regards to the ISFEs, we've had to cancel quite a few of them, which has had an impact, particularly on a lot of the specialties. We have a lot of candidates coming through, for example, orthodontics, restorative dentistry, and pediatric dentistry. They are the three big ones, basically. And I'm so mindful of the fact that and again, I apologise to the trainees that we had to cancel these examinations at short notice. I do appreciate how much time and effort you've put into actually getting to the examination, and to suddenly hear a few days beforehand that the exam's gone down must be heartbreaking. And as I say, I apologise profusely for doing that, but we felt it was the right decision to take, and then looking at it with the old retrospective scope, and in hindsight, it was the right thing to do, given of where we are now in the situation with COVID. Going forward, which we should be doing and looking at things, we will come out of this. There is no doubt about that. The big question is when. None of us have a crystal ball, unfortunately. There's so many computer projections about when it's going to peak, when it's going to plateau, when the peak's going to descend. Is there going to be a second peak? So we're hoping that we would be able to deliver these examinations. The examinations start again in September for the ISFEs, and going through September and November. If we can deliver them in the traditional way, which we hopefully did, then fantastic, we can do that. But if not, we're looking at other ways of delivering these examinations using online platforms rather than using face-to-face platforms. So again, Mike said, it is fluid, things are changing, but I would hope, you know, and I use the word hope, that we would be able to deliver these examinations in some form in September and November, and not disadvantage anybody. There is no way that we are going to extend anybody's training, or that's not the idea. I mean, obviously that's down to HEE, the postgraduate deaneries. But as I say, as a college, we will try and support your training in any way we can. And the idea is to run the examinations, hopefully either traditionally, or if not, or on an alternative way, come September, November, basically.
Fraser, I wondered if, as your college hosts the tri-collegiate specialty memberships, whether you had an update on how those are progressing.
And the other ones would be the various routes to specialty endodontics, prosthodontics, and periodontology and orthodontics. There was a belief when all this started, and I reiterate, this is a very fluid situation. It's changing almost by the day. that we could all suspend everything and it would be very busy at the end of the year. I mean, even today, we now get notice that a conference that was due in September has been cancelled for us. So I'm not sure quite whether we can delay as much. And there's a challenge from COPTEND and the deans that we cannot delay the trainees. It's not possible, because that will then compromise recruitment to those posts. So there's definitely going to be some form of assessment. And my advice to any trainees listening, they've got to prepare for these exams and do not wait for September, October. Be prepared for something potentially July or August. But obviously around the strategy of that, we've got to put in place the logistics. We've got to put in place the security of all the assessments to make sure that once the assessments aren't out there, done in a remote way, we don't lose control of the question banks and then the intellectual property rights, so that the individuals have free reign to get to the questions so that they can then answer them without really testing their knowledge and skills. But there's an awful lot of hurdles to get through before we get to that stage. The one thing that's probably helped crystallise our minds is that the General Dental Council are reviewing specialty assessments in the various colleges. They've done Glasgow, they're currently about to do Edinburgh. And I think that also gives us a unique opportunity to try and bring some standardisation to the assessments. But I would again reiterate, trainees must continue to prepare for assessments in some form, but they will still be assessing the knowledge as required for the specialist list applications.
Sounds good. So I think just to reiterate, the take home really is we're really working hard with all the stakeholders to try and minimize any disruption that could occur. And actually, as Fraser said, if we can by any way get these exams up in an alternative format earlier rather than later, that is the route we would prefer to go. We think it's in everybody's interest, particularly in a fluid situation where one can't be certain as to when the situation will change from where we are at the present time. So to reassure you, the colleges are actively pursuing every opportunity to bring these exams back at the earliest opportunity. So as Fraser said, I think very helpfully, do not think that these exams are totally siloed or put off or mothballed for 6 months or 9 months. That is not going to be the case. All right. Jane, oh, sorry, Andy.
I'd just like to add, Mike, as well. Obviously, there's probably a lot of DCTs out there and VTs as well, listening about the MFDS exam as well. The same thing goes for the MFDS, the part one of the MFDS, whether it's sat through either the Glasgow or the Edinburgh College or done through Mike's College in London. The part one, as you know, is an MCQ. That can be done remotely. That can be done online as well. So if you're intended to take that exam, please study for that exam, because there are ways and means and platforms that we can offer that examination. The part two is slightly more difficult. It's an OSCE examination, but again, we're working at different ways of delivering these examinations. So as Fraser said, please keep studying for them. We don't want you to suddenly think, well, nothing's going to happen for 6 months. All of a sudden you find an examination is going to be there and present and say, I haven't studied for it. We're not doing that. We don't want to cause this logjam, as we talked about as well. So it's not business as usual. But as I say, and obviously it's difficult in the current climate for people to go away and say, well, I've got to study in this climate. It's very difficult, and we appreciate that. But as I say, we would like to deliver these exams right across the board in all specialties, whether it be membership exam, specialty membership exam, or fellowship examinations.
Okay, we're getting a few requests to move on. So we've had a few questions regarding people wanting to know where they're likely to be redeployed to, and how to make sure that during that time that they are still able to prepare for the next stages of their career.
Fraser, would you like to take that one?
Yeah, I'm conscious, hopefully we're recording this and it'll go out. So the publications approval reference that's fairly recent from the NHS is 001559, and it's deploying the clinical dental workforce to support the NHS clinical delivery plan for COVID-19. And basically it's about the dental, and if you watch Sarah Hurley's webinar, it's quite clear. This is an opportunity for dentists to prove how flexible they are and move into the areas to help support the NHS deliver the care that is needed during this time of epidemic. It is obviously, you've got to bear in mind the business that the General Dental Council require to work within your own competencies. But there are all sorts of ways people can be deployed. Now, there are a few teething problems and people have to be patient with those, but there is a huge scope, certainly in the secondary care setting, to help running a hospital, and also in the local communities to help support. So I think you're all advised to read that document and take from it the sensible caution that you can actually help and support this situation.
Anyone else like to comment? Andy, Albert?
Yeah, I think you're absolutely right, Fraser. There is definitely scope. We have a lot of what I call transferable skills. I am not asking a dentist to suddenly go into intensive care and manage somebody's airway. That is not going to happen. I've heard lots of things on the Twitterati about patients being going, oh, I'm going to be put into ITU. No, you're not going to be put in ITU. You're not going to be managing an airway in a patient. That's what anaesthetists are there for. That's their job, is to manage airways and that. Any area, as Fraser said, you go into, you have to feel comfortable. You have to be trained, appropriately mentored and appropriately guided. At any time you are out with your comfort zone, then you can turn around and say, stop, I'm out with my comfort zone. I am not happy. That's the right thing to do, basically. If you are working within the hospital environment, people will talk about indemnity, Crown indemnity, or the hospital indemnity will indeed cover you as long as you've had the appropriate induction and training and mentoring for whichever role you're going into, basically. But there are a lot of ways that dentists have got superb skills, whether it's not all about their clinical skills as well. Dentists have got very, very good management and indeed leadership skills as well. And that's sometimes needed in a hospital environment. Where there are multiple teams of people, is somebody to take a leadership role as well. So there's a lot of non-clinical roles, which I think dentists would be very, very good at, as well as some clinical roles as well. But it's a very good document. As I say, stay within your area of competency, stay within your comfort zone as well. Don't stray out with it, as I say, because there are a lot of things it can be done for you guys to come in and help, whether it be in the hospital environment, whether it be in the primary care environment as well. To help supplement the NHS in these quite trying times.
So I think one of the important points as well is there are opportunities not just for the dental clinician or the dentist, but also for the dental nurse and also for the support staff in terms of the receptionists and practice managers. You have really highly valued skills in terms of logistics and organising things, which the NHS is really needing at this present time. So the whole dental team has the opportunity to contribute, and I think the framework for redeployment clearly articulates some of those opportunities for the whole of the dental workforce. Ian, I wondered if you'd like to comment, particularly as you're in primary sector particularly.
I think, as you know, Andy has said, that we have got transferable skills within general dental practice. To me, you know, we've heard a lot about the importance of leadership and communication. I think one of the key things in this crisis at the moment is about teamwork, and it is about adapting and to fitting in with whatever role we might be asked to do. And I think it's about the attitude, actually, and it's fantastic to hear that you know, there's over 13,000 people that when at the last count I heard, that had come forward to volunteer. And you know, I think we, as a profession, we can make a contribution, and we should be making a contribution if we can. But just to reassure people, it's not conscription, it's voluntary, and there'll be many out there for various reasons why they might not be able to step up and help within secondary care or in general practice, but they can still play an important role in terms of within their own practice, triage, or supporting other friends and colleagues. So there's still a lot of jobs you can do other than that are just within the guide document.
So I think it's also important to say, as Ian has, that there is an opportunity. If you're an NHS employee, you may be redeployed. If you're not within the NHS, there is a portal that you can volunteer your services, and I think they'll be only too happy to take you. So for anyone who's not actively engaged in NHS activity prior to the changes that we've seen, there is still an opportunity for you to volunteer through the portal and be redeployed in an appropriate way. Jane, how are we with any follow-ups or moving on?
Lots of questions coming through. So one very, very quick one. Fraser, could you repeat the number of the document you referred to so that people can write it down?
So it is only available for England, but it's 001559, and it was published on the 4th of April 2020, entitled Deploying the Clinical Dental Workforce. I'm sure if you Google just that, you will find it. But I mean, the bit that it doesn't stress in it, dentists always sort of belittle themselves. Usually during the working day, they are dealing with a stressful situation. At the moment, the country has a lot of stressful situations. We manage to diffuse those by simple soft skills, and I think we shouldn't underestimate that, what we're capable of delivering and supporting.
And
I would also just sorry, Mike, just a non-registrant group, which is dental practice managers, and I would put a shout out for them that certainly in terms of organisation, logistics, you know, if my practice manager wasn't in place, we wouldn't have a practice. So I think there is certainly scope and opportunity for them and the dental reception team as well. So you know, I think we need to think laterally, look at these transferable skills that would be useful to utilise.
And be aware that if you do need a bit of a freshen up on your skills, that training will be provided when you get to the location that you're being deployed to. So I think, as Andy said, you should be comfortable in it. There will be the requisite training. I know in my own trust, we do have some dentists who've gone off to work on the wards and are helping in A&E and in ITU with appropriate training and support and within their comfort zone, depending on what previous experience they have had, either in primary care or indeed in secondary care. Jane, how else would you like us to go forward?
Okay, so we've got quite a few people raising the point that should all patients be treated as potential carriers, and should we be deferring treatment where possible to reduce the risk of spreading the virus?
Albert, would you like to take that first?
Yeah, I think it's a matter of common sense of what the best practice is. Every procedure carries a risks. And so we're looking at what the best possible practice is, and we're looking at what the different guidelines are in different sectors, different countries, and what they are. I mean, for instance, if you look at the use of masks there, FFP1 mask has a protection factor of 4, FFP2 mask has a protection factor of 10, FFP3 mask has a filtration rate of 99.95%. So in actual fact, there, irrespective of a risk there, wearing FFP3 masks there will be a lot less risky in exposing yourself to the quantity of virus, potential virus that's going to be around, compared to, say, just a normal surgical mask. So you need to look at those very, very carefully and look at also the guidelines. I know that different home countries and islands have got slightly different emphasis on the guidelines as to what you should or shouldn't do. But I think what's most important to look at is what is in the patient's best interests in relation to protecting them and protecting yourself as well. This is a very, very fluid situation. There's no absolute right and wrong answer, and that's why the 4 home nations are trying to come up with a consensus situation with their respective situations for tomorrow. Ireland's situation is slightly different in the sense that we have had the guidance from the health protection surveillance centers and others, but it is moving towards the same directions in relation to what is good practice and what is good for our patients as well.
So I think it is important that we try and minimize the amount of dentistry that we do. It should be dentistry that is urgent or emergency care. So routine treatment, we should be deferring, and treatment that would not make a difference to the outcome, we should be deferring. So a simple take home is we should do as little as is necessary to render that patient stable for the foreseeable future. I don't know, Ian, you were wanting to say something, I think. I'm sorry.
No, I just think at this point in time, with the limited testing that has been done and is available, we must consider everyone to be a carrier. And your dentists are used to applying universal precautions. And I think you know, most dental practices, or the majority of dental practices, work to an exceptionally high level in terms of cross-infection control. But in my limited knowledge, I would say that we ought to be treating everyone as a potential carrier of COVID-19. The issue comes around risk, as Albert said, but the risk should be based on the procedure that's been undertaken, perhaps, rather than the individual crossing our threshold.
Yeah. So I think again, it's
the other background. Sorry, Mike. The other background is the challenge from the A&E doctors. They don't want A&Es full of dental facial swelling. So we've got to have that in mind. So stabilize and make sure there's nothing that could potentially cause a problem that will then suck up the NHS resources.
That's as Fraser said, that's a slight concern we have in the secondary care sector, is we are going to see a significant rise in the people admitted with cervical facial abscesses secondary to dental problems, and it's trying to deflect people away from that, because our A&E departments are overwhelmed at the moment, obviously, with patients who are indeed COVID positive and got lots of symptoms regarding that, and the idea is to keep people away from A&E. Ian's take on it, guilty until proven innocent. In this day and age, they reckon that possibly up to 80% of the UK population will be infected or will have been infected. And we find that there are asymptomatic carriers out there. The testing that we've got at the moment is poor. The government do know that. They are frightened to admit it, but it's poor. They're trying to get their head around it at the moment, but what they're testing at the moment is we're only testing for the virus. We're not actually doing an antibody test at the moment, which will tell you whether or not you have been infected, which will be very, very helpful, because then you'll be able to detect who's been carrying, and you'll be able to detect the asymptomatic carriers. And we find that 5 to 10% of the population will be asymptomatic carriers, and that's come out from a lot of studies that have come out from Wuhan and from central China as well. So I think in this day and age, yes, avoidance is the main thing. Avoid if you can. But if you have to treat, appropriate protection and appropriate PPE.
Okay.
We've had a couple of comments regarding the use of antibiotics. So it's more of a statement than anything. So if we provide antibiotics rather than intervention, A&E can become involved. Should you be prescribing antibiotics to avoid further intervention?
I think you should when it's appropriate, but in most instances, antibiotics are not appropriate for the management or treatment of dental pain. We're in an unprecedented situation, as Andy has explained, and but that still doesn't mean to say that we should be compromising the standards. I don't, for two reasons. One is that antibiotics doesn't help with inflammatory dental pain, and secondary, we're storing up a problem for further down the line. But it is that we're in a compromised position at the moment. And it's very, very difficult when we don't have urgent dental centres to care for these people with irreversible pulpitis. So the focus has got to be on developing services to deal with these patients, and then there won't be any desire or pressure on the profession or the patients to demand the prescription of antimicrobials.
I think there's very good guidance from SDCEPT, which goes around about drug prescribing for dentistry and indeed dental emergencies, and the judicious use of antimicrobials or antibiotics, because as Ian said, antibiotics are absolutely not indicated for an inflammatory process.
Okay.
Next question, Jane.
So we've had some people asking why every dental hospital couldn't become an urgent treatment centre, as they have all the appropriate specialists under one roof. I feel there's probably a logistical reason.
There may be. Certainly, I know Guy's and St Thomas's has become an urgent. It's a centre that's already up and running and has been providing care for several weeks already, and has been working very well. I'm not sure about other areas around the country, as Ian has already alluded to. I think it is variable at the moment, but they are all working towards it. And obviously there are only 14, I think, dental hospitals, and so that would not, I suggest, cover, particularly at a time when we're trying to do social distancing. We do not want patients to have to travel some huge distances to try and get dental treatment. So there is a balance between focusing on those dental centres and actually a need to have some others. I'm thinking of the nearest to somewhere like Exeter is probably Plymouth or Bristol. So we've got to think, how else can we supplement those teaching hospital facilities?
So we've had a couple of people flagging that all London hospitals and that the Scottish emergency care centres are up and running. Moving on slightly, we're getting a lot of questions. on slightly, we've had a lot of people asking questions about how they would go about getting mask fittings, given if they're not in a hospital setting.
So my understanding is that those urgent care centres are actually doing mask fitting. So that's certainly been happening in London, where people have been going to have their fit check, well, not just fit check, but actually being fitted for their FFP3 masks. So I would suggest that that will be run by the centre in which the care is being delivered. Andy, I don't know if you have any comments on that.
Again, that should be where, you know, fit testing. I mean, it's done. I mean, hospitals are doing them all the time. We've gone through thousands of our staff have been fit tested, but it should be in the urgent care centres for the provision of FFP3 masks, and they have to be fit tested appropriately, basically, because there are several types of FFP3 respirators that are around. Some are N95, some, as Albert said, are FFP2 or indeed FFP3s, and there are various makes, models, and that as well that are around. So what you might pass on one, you may well not pass on another.
Ian?
I guess really just a point of availability at the present time. You know, that seems to be the main issue. My understanding is that to become a trainer in fitting an FFP3 isn't overly arduous, from what I understand in the West Country. So I think it's getting available supplies that is the absolute issue.
Okay. Over to you, Jane.
Sorry, just getting a lot of questions through. On a slightly different note, we've had a couple of questions regarding prison dentistry, which is niche, but is important. So there doesn't seem to be any guidance specific to the prison service. We can't follow the guidance for primary care as we don't have the ability to undertake phone triage, and prisoners cannot feasibly enter urgent care centres. We don't have enhanced PPE, although attempts have been made to procure it. Can you give any guidance on how situations like this could be managed?
Andy?
Might be one to take offline.
I mean, I think
it's a unique situation, that actually, prison dentistry. It normally sometimes falls under the remit of our special care dental colleagues. They often cover prison dentistry, but again, it's trying to mitigate anything that involves active dental treatment. The problem is if a patient is neglected, any patient, now whether that be a prisoner or that, and they don't get the requisite treatment, then what happens is they may end up in my hands. They may end up coming to hospital with a significant facial swelling and significantly unwell as well. So there should hopefully, I mean, I'm not involved with the special care dental service or indeed the PDS and what remit it has basically, but it's trying to mitigate against them actually, you know, coming into it and actually doing something for them.
so. I think, as James said, though, I think it'd be helpful. That's an area that we might usefully as a group take forward, just to see if we can get some clarification. And I thank you for raising the question. It's not one I'd thought of, in honesty. I don't know about other deans, but certainly something we can take forward. And it was one of the reasons for reaching out to the membership, was to see where are these areas that we might be able to, in the words of others, lean in and try and help with. So thank you for that question.
Brilliant. Still coming through thick and fast. We're getting a lot of people asking about how to train as a mask fitter. I'm going to suggest that we probably circulate some sort of the answers to more generic questions after the event. So sorry if we don't get to those. We have had a comment that it's great to hear how valuable the dental profession is, but why are we seeing so little of us in the news? We never seem to be mentioned when NHS staff are described. Any comments?
I'm looking at...
Well, I think some people in the West Country would maybe beg to differ. It has had quite a high profile down here recently. But I guess, you know, in the scheme of things, when you do have patients dying in hospital and in care homes, and the crisis that's affecting the NHS at the present time, it's not surprising that dentistry maybe falls down the list of priorities. I guess part of our responsibility as deans of the dental faculties is to make sure that it still has high priority, and that we are there to champion both our members, the wider dental workforce, and particularly our patients. So, you know, I think there are pockets where there is media interest, but it probably again comes back to access. And where there are issues around access, or an individual has had a problem, that will probably be highlighted.
And I think you're only just seeing the beginnings of redeployment. And I think it'd be interesting to see what the perception is when we do see more and more dental practitioners and their allied teams actually working side by side with the medical teams. And when that message starts to come through loud and clear, we're in the relatively early stages of that at the moment. So, you know, whilst we might hope it doesn't last long, I have a feeling that we will be here for quite some period of time. And so there will be an ongoing opportunity for the dental workforce to engage in making a difference.
I think Mike's right. It's what we want is good news stories out there about dentistry, because unfortunately at the present time it tends to be bad news stories that get the press coverage.
Yeah.
I'm just getting some more feedback from some of my dental colleagues about how they've tackled the prison problem. So again, it's something we can maybe take offline. So
Yeah,
I've just got
and
some feedback personally. Yeah,
we can circulate through. Just to everyone who's asking questions, we are getting a very, very high volume and it's quite hard to keep up with them. So we will go through them afterwards and we will try and point people to guidance in the next couple of days. It's worth keeping an eye on our social media and any post-event emails. So do bear with us. I'm sorry, they are coming through thick and fast. So one question that's come up is about it's again about AGP. There seems to be confusion around high volume aspiration acting as an AGP. These statements appear to be based upon medical suction rather than dental. Evidence supports the position that dental high volume aspiration leads to a reduction in aerosols. Could the panel comment?
Well, I think we've commented in the sense that we're about to go into a discussion with the relevant parties around the evidence base, and that what will come out from that should address all of those questions, I think, rather than carrying on with those at this stage. And so we would hope to have closed that out to everyone's satisfaction. I would support the statement they've made, and I think we'll have to see how we work that all through over the next few days.
I agree with Mike. Again, this stuff is, if you want a paper, I'm not an academic. There's a paper that's just come out of China, International Journal of Oral Science, which talks about transmission routes of COVID-19 and controls in dental practice. And it does talk about high volume suction as a methodology of reducing bioaerosols. So if you want to have a look at that, Google it, I'm sure, as I say, but no, I do take that on board. But hopefully, as Mike said, we'll encompass that all in our document, which hopefully will come out around AGPs and what does constitute an AGP and what we can do to reduce an AGP.
Okay, sorry.
It's all right.
You caught me on the hop there. I was reading back.
Sorry, Jim.
It's all right.
Can I just jump in? Sorry, while we've got a slight pause.
Yeah,
I mentioned earlier that our priorities have got to be around safety, and then secondly around addressing urgent dental care problems. But within general dental practice, the other big issue that has to be addressed is the sustainability of dental practices long term. And this isn't necessarily just around the financial importance for individuals or practices. It's also about coming out this crisis and making sure there is a network of general dental practices that are available to deliver the level of care that is required for our population. And I understand from my inbox and the many messages I get that is a real concern for practice owners and associates up and down the country. Is we have to make sure that we come out of this in as strong a position as possible to provide for our patients. And again, I know the other deans and myself are all working with the CDOs and the British Dental Association to try and do our best to make sure that we safeguard our profession going forward.
Yeah.
Okay. So we have been asked if the indemnity organisations have a view on treating patients in the current environment. I don't know if that's again a bit too specialist.
Well, go on, Ian.
Some of the advice I've had on some of the meetings are just the importance of triage and documenting your records. and also discussing the risks and the benefits to treatment with the patient, which goes beyond just the clinical discussion. So again, it's taking a relevant history, in terms of have they had a cough, have they had a fever, the risks about coming into the practice of the urgent dental care centre, that has to be clear and it has to be well documented. And it would also be useful to actually refer to the current guidance at that time. So, guidance is changing so rapidly for us all at the moment. It is worthwhile just referencing that you are complying with the current guidance by NHS Scotland or NHS England or wherever.
It's also worth noting there's a very useful statement that the General Dental Council issued just last week, which included clear guidance on how to document your telephone conversations, how to document your decisions around remote prescribing of antibiotics, and addressed exactly the concerns that Ian was speaking of. So I think the GDC have actually done everyone a favour in producing a very clear document with links to specific examples of how one should go about this in order to minimise risk in terms of being called to order for not having documented it appropriately and not being able to justify your decisions.
Okay, we have only got a few minutes left. I'm a bit mindful of people's time, and like I said before, we have had a lot of questions. We will try and answer as many offline as we can. We've got a few people asking about recruitment for September 2020. So what are the plans for DCT and specialty training recruitment for September 2020 to ensure that the workforce is in place as required?
So we had a meeting, and in fact, I think it was Fraser and myself sat on a meeting, which was an all nations meeting chaired by David Felix, who's the chair for COPDEND, only last Thursday, in which we've gone through and agreed as a group all the processes in order to move forward on a recruitment as previously planned. I think that's correct, isn't it, Fraser?
It is. And the one issue that's tied in with all that is that we actually get people completing their specialty training programs. So it is tied in with the assessments.
Yeah, but not so much for DCT.
No.
No. So yeah, it's all in hand. There is a task and finish group already working on it. It met, as I say, last Thursday for the first time. I can't remember quite when we're meeting again, but everything is a very short time frame at the current time. So I would envisage that they will put out an announcement at the earliest opportunity.
It's Thursday, Mike.
Yeah, there we go. It's that quick.
There you go. And I'm going to suggest that will probably be, we've got a FDS on the RCS England website. We've got an FDS COVID-19 hub, so we will continue to link and point to those resources. And again, we will share those with the post event so people can find all the information that they need. We are quickly drawing to a close. We've had a few people asking about exit strategies.
You want me to go with this? So the challenge that we have is that this is so fluid that I think it's far too early to think about an exit strategy. I know that's the same sort of thing that the politicians said, but it is. Part of how quickly we get to the end of this is how successful social distancing is in flattening the curve, and how long it is until we can get down the other side, and how soon the government can start to relax some of the regulations. You've seen in Hubei province, it's what, 4 or 5 months after the event. So it gives you some indication potentially, but every country will be different, and every epidemic within those countries will be different. So I think we will need to watch how that plays out as we go forward. And they may be able to relax, but of course, if you get a second spike starting, then the government will need to react to that in order to protect the NHS and protect lives, as it's rightly said. I don't know if any of the other deans wish to comment.
I think we're still in a very early stage of this pandemic. There's a lot of fluid situation unknown that is around. Depends on how it goes, depends on how flat the curve is, capacities, depends on compliance, depends on whether there's going to be a second spike coming this winter, and depends on how the vaccine goes. There are 14 different trials going on at the moment. See whether some of them can progress much faster than the others, I think.
We will come out of it at some time. I know that. That's as sure as eggs are eggs. We will do. But but it's when. We just don't know, basically. So it's a bit early to start talking about exit strategies at the moment, but when the time comes, we will talk about them. Just before we go, I just know everybody out there is scared. I'm crapping myself. Every morning I got to go into the hospital. My blood pressure goes up and my pulse goes up. So you guys must be the same. It's created a huge amount of anxiety, not just in amongst our profession, but right across the board. People are frightened and people are scared, but just hang in there. As I say, we as colleges are there to try and support you guys and help you guys and inform you guys about things as well. So it's all about that. But just as I say, have faith, there will be light at the end of the tunnel eventually.
I would endorse what Andy has just said. Based on my experience in general dental practice and all my colleagues there, it is a very, very difficult, tough time, and we tend to focus a wee bit more on the NHS, partly because of secondary care, partly because of the relevance of the NHS organisations. But this is a real problem for mixed practice and private practice. And as I alluded to earlier, we have to safeguard them and protect them, because although the landscape for dentistry is going to be difficult when we come out the end of this, we need to make sure that that is sustainable and we do have access for patients, whether that's NHS, mixed practice or private, because dentistry and our patients will be in a much worse position and there'll be much greater inequality if we don't look after that service.
Okay. Final thoughts?
I was just going to say, to add to that, Ian, I mean, the finances of everybody worrying about where they are in their current posts and in terms of the practices, the local dental committees have got a lot of information about furloughing staff and income generation and that potential. I think people need to get their own network set up and contact their local dental committees to get that information. Because if we don't have practices left after this, we are going to be in a worse state than before.
Absolutely, and I would just jump in and I'd say that the Faculty of General Dental Practice website has a really useful resource where a lot of that information has been pulled together, the LDCs, the PDA, but most of all, we need support from our colleagues, and it makes a big difference if you can set up these small WhatsApp groups and just realise that you're not alone, and there's many others that are going through the same problems as you are at the moment.
Albert, final thoughts?
Yeah, just wish everybody very, very best of luck. I think this unprecedented situations, we all in it together, with respect to where we are. We all look at different spheres of practice, faces different challenges. I think it's important thing is to say that as deans, as colleges, we are all with you, wherever you are, and stick together, we'll get through that.
So I think we'll draw it to a close at that point, if we may. I'd just like to thank everybody for participating. I think we've broken the record, if I'm not mistaken, so that's great. We do envisage doing this again, if it would be helpful to you, which I think, judging from the number of questions, it probably will be. Thank you to everyone, and I think signing off, it's be well and be safe, are probably the two key words at the moment. So thank you very much to everyone. And we are thinking of you. We are actively as a group, and it is truly as a group, working to try and move forward the profession, as are many other organisations within the sector, and not to be underestimated. I'm stunned by just how many hours people are putting in at the moment to try and move this whole effort forward for everybody across the piece. So thanks very much for your engagement tonight. Thank you to all my fellow deans. Truly collaborative exercise. I think we'll all sign off.
Yeah, just to very quickly highlight on behalf of the English College, we have got a health and wellbeing webinar next Wednesday, which is open to all members, fellows of all of the colleges, and it's focusing on the impact of mental health during the COVID-19 outbreak. So if anybody is interested, please do join, and it will be advertised as of this evening, I think. So thank you.
Okay, thanks very much, everybody. Have a good evening. Bye.
Thank you.